I want you to picture a mechanism you rely on every single day. Multiple times a day, actually, probably without ever giving it a second thought.
Right, something entirely automatic.
Exactly. You sit down for your favorite meal, you take a bite, your teeth break it down, and your tongue pushes that food to the back of your throat. And then, well, your conscious control essentially just ends.
Yeah, autopilot takes over from there.
Right. This whole complex series of involuntary muscle contractions is supposed to seamlessly transport that food down a muscular tube, the esophagus, and just drop it safely into your stomach.
Which works great until it doesn't.
Right. Imagine for a second if that autopilot fails. You chew, you swallow, and suddenly there is a hard stop. The food physically will not go down.
Oh, it's terrifying.
It's a deeply alarming, really claustrophobic sensation. You can feel the pressure building right in your chest. And it happens because the esophagus has completely narrowed.
It forces this completely invisible background process right to the forefront of your attention.
Yeah.
Because when the physical architecture of that tunnel is compromised, like the basic mechanics of human survival become an immediate crisis.
I mean, you literally can't eat. So for today's deep dive, our mission is to unpack exactly why that structural compromise happens. You know, the mechanics of why our throats sometimes just decide to aggressively close up on us.
And, maybe more importantly, how we fix it.
Yes. We are going to explore the utterly fascinating and frankly somewhat intense mechanical ways that doctors go in and pry that passage back open.
It's quite the toolkit.
It really is.
Yes.
And to do this, we are drawing heavily from a fantastic medical lecture video that just breaks this entirely hidden world wide open. It's titled HCC 1475-30A Stricture Dilation Concepts.
Yes, straight from the YouTube channel of Dr. Gautamakoa S. Raju.
Right, Dr. Raju. And this source material is honestly a masterclass in how gastroenterologists approach a problem that is, at its core, a major plumbing disaster.
The plumbing comparison is actually a highly effective way to visualize this. Because, I mean, when water won't drain from a sink, you don't just pour chemicals down the pipe and hope for the best.
Right, you call a plumber.
Exactly. A plumber has to evaluate the physical nature of the blockage. You know, is it a localized clog? Or have the actual walls of the pipe degraded and collapsed inward?
Which changes the whole approach.
It changes everything. And the medical equivalents of those questions are foundational to Dr. Raju's lecture. Before a doctor can introduce tools to fix the blockage, they absolutely have to map the terrain. They need to understand the biological events that warped the pipe in the first place.
Because it's not like you just swallow a large unchewed tortilla chip and it gets permanently wedged in there, right?
Right. Yeah.
The actual walls of the esophagus are changing shape. The lecture uses the term stricture to describe this narrowing. Specifically, a peptic stricture.
Yeah, peptic stricture.
And if we trace the timeline backwards, like it doesn't happen overnight. It starts with severe esophagitis.
Which is severe chronic inflammation of the esophageal lining. You have to remember, the esophagus is lined with delicate tissue that is just not designed to withstand the highly corrosive, acidic environment of the stomach.
Right, stomach acid is intense stuff.
Extremely intense. So when stomach acid repeatedly washes up into that tube over a long period, it causes profound chemical burns.
Okay, let's unpack this. So the body obviously has to respond to that chemical trauma.
Yeah.
I mean, when I get a bad scrape on my knee, my body rushes to patch the wound, right? It forms a scab.
Right.
And eventually that turns into a thick scar. And if the scrape is bad enough, the skin pulls really tight as it heals. Like you can literally feel the tension in the skin around a bad scar.
Yeah.
So is the inside of the throat attempting that exact same biological repair process?
The underlying mechanism is identical, yeah.
Mm-hmm.
The body recognizes this severe ongoing damage from the acid and just goes into a state of hyper-repair.
Like it's panicking.
Exactly.
Okay.
It lays down massive amounts of collagen to patch the chemical burns. And in medicine, this buildup of heavy scar tissue is called fibrosis.
Fibrosis, right.
But here's where the structural problem arises. A healthy esophagus is dynamic. It's a flexible, muscular tube that actively expands and contracts to push food downward.
Right, it's not just a rigid drain pipe.
Exactly.
Yeah.
But fibrosis has none of those elastic properties. It is rigid, it's tough, and it's completely unyielding.
Oh, wow. Which means the body's own defense mechanism is actually creating the mechanical blockage.
That's exactly it.
The scar tissue builds up, layer by layer, to protect the throat from the acid. But in doing so, it shrinks the diameter of the tube until a piece of food just can no longer fit through, The healing process literally becomes the disease.
It is a profound biological irony. I
Yep.
mean, the fibrosis is a desperate natural attempt to stabilize the tissue, but the resulting rigid, narrowed passage, the stricture, costs the patient their ability to swallow.
That is wild.
Yeah. You have a structural failure that evolved directly out of a chemical injury.
Yeah.
And once that rigid scar tissue has formed, you can no longer treat it with antacids or chemical solutions.
Right, the damage is structural now.
Exactly. It demands a physical, mechanical intervention.
So the doctor has to go in and physically break the scar. But before they can introduce, any kind of battering ram to force that tunnel back open, they have to know exactly what kind of terrain they are navigating.
You need a map.
Right. And according to Dr. Rogers' material, every stricture is sorted into one of two very distinct categories, simple or complex. And the entire game plan hinges on which category you fall into.
Because the categorization dictates the risk profile and the tools required. Let's look at the parameters for a simple stricture first.
Okay.
To be classified as simple, the narrowing must meet 3 strict geometric criteria. It must be short in length, it must have a straight path, and it must be relatively wide open, even though it's causing symptoms for the patient.
Right. Let's ground that with the examples from the source. The first one is called a Schatzki's ring, which, aside from sounding like a very expensive piece of jewelry, happens at a very specific anatomical border,
Yeah, it occurs just above the G-junction.
the gastroesophageal junction.
Exactly. This is the exact frontier where the esophagus meets the stomach. At this border, there is a transition in the type of cells lining the organs. The squamous cells of the esophagus meet the columnar cells of the stomach lining.
The squamous columnar junction.
Right. And in some patients, the tissue right at this cellular border becomes thickened and inflamed, and it grows inward to form a literal physical ring around the inside circumference of the tube.
Like a structural speed bump right before the stomach drop-off.
That's a great way to put it.
And then the second example of a simple stricture is a mucosal web, or a membranous web, which to me sounds like Spider-Man was in there. But I'm picturing a thin, fibrous membrane stretching across the inside of the tube, almost like a localized net catching the food.
That is a very accurate visualization. It's this thin layer of tissue that partially obstructs the lumen, which is the open space of the esophagus.
Okay.
But notice what both the Schatzki's ring and the mucosal web have in common. They are highly localized, very short, and they don't alter the straight line trajectory of the esophagus itself.
Okay, wait, I have to pause here. Because if I'm the listener, and I've just experienced the sheer panic of choking on my dinner, hearing a doctor call my blockage simple feels like a massive disconnect.
Oh, absolutely.
I mean, a ring of scar tissue or a web in my throat doesn't feel simple to me. Is simple just a doctor's way of saying easy for me to fix?
That is such a crucial distinction to make between the clinical vocabulary and the human experience. When a gastroenterologist designates a stricture as simple, they are not minimizing the patient's distress
Right,
or the severity of the choking sensation.
right.
Simple is an exclusively geometric classification.
Geometric, okay.
Yeah. It means that when the doctor lowers a camera into the esophagus, they have a clear, unobstructed line of sight straight through the narrowing. The path does not deviate. They can visually confirm the healthy tissue on the far side of the blockage.
Okay, I get it. So if simple just means a short, straight tunnel with a clear exit, then the criteria for a complex stricture must be the exact opposite. And looking at the list of traits for complex strictures in the lecture, they sound like a navigational nightmare.
They are exponentially more dangerous to treat. A complex stricture is defined by the absence of those simple, straightforward traits.
So they aren't short and open.
Right. Instead, complex strictures are tight. They are severely narrowed, much like the extensive, thick peptic strictures we discussed earlier, where the fibrosis has built up heavily over time. And furthermore, they're frequently angulated.
Meaning the tunnel actually bends and twists.
Exactly. The stricture alters the anatomical course of the esophagus. It creates a jagged or curving path. And because the passage is either so incredibly narrow or because it physically bends out of the camera's field of view, complex strictures are visually opaque.
Visually opaque, so the doctor cannot see daylight at the end of the tunnel.
Right. They're staring into a dark, blind curve of scar tissue. And additionally, if the doctor spots any active ulceration, meaning open, raw sores within the stricture, that instantly elevates the classification to complex.
Wow. Okay, so the map is incredibly clear. Simple means short, straight, and visible. Complex means tight, twisting, dark, and potentially wounded.
Precisely.
So the doctor maps the terrain. Now, they have to physically clear the blockage. They have to break the rigid collagen that has choked off the pipe. And Dr. Raju's lecture outlines a specific toolkit to achieve this, relying on 3 primary tools: bougies, balloons, and guide wires.
Let's examine the mechanics of the bougie first.
Okay.
A bougie is a specialized medical dilator. It is essentially a long, semi-rigid cylinder, often tapered at the end. Its function relies entirely on physical, forward mechanical force.
Like a battering ram.
Pretty much. The doctor passes the bougie down the esophagus and physically drives it into the stricture. As the tapered end wedges into the narrowed space, it forces the heavy scar tissue outward, physically disrupting and stretching the fibrosis to widen the passage.
Okay, so it operates purely as a physical wedge. You are applying linear force down the pipe to pry the walls apart. But the second tool, the balloon, operates on a completely different axis of physics.
It does.
Because the doctor isn't pushing a wedge forward, they are passing a deflated balloon down into the exact center of the narrowing, and once it's perfectly positioned inside the stricture, they inflate it.
Right, so the mechanism shifts from forward pushing force to radial inside-out expansion. And the substance used to inflate that balloon is highly deliberate. The lecture notes they can be pneumatic, meaning inflated with air, or hydrostatic, meaning filled with water.
Wait, why choose water over air? I mean, air seems lighter and easier to pump.
It comes down to predictability and control under immense pressure. Air is a compressible gas.
Okay.
If you use a pneumatic balloon and it encounters heavy, unyielding resistance from a thick wall of fibrosis, the air inside will compress. The pressure builds and builds until the scar tissue finally gives way.
And that's bad.
Well, when it gives way, it can happen suddenly and explosively because the compressed gas rapidly expands. Water, conversely, is an incompressible fluid.
Oh. So if you pump 5 milliliters of water into the balloon, you get exactly 5 milliliters of physical expansion.
Yes. The expansion is absolute, immediate, and entirely predictable. The doctor has millimeter by millimeter control over how much radial force is being applied to the walls of the stricture.
So it stretches it outward smoothly without the risk of a sudden, uncontrolled snap.
Exactly.
That makes so much sense. Okay, so we have a linear wedge with the bougie and we have radial expansion with the balloon. But it's the third tool in the kit that seems out of place at first glance. The guide wire.
Ah, the guide wire.
It isn't a dilator, it doesn't stretch anything, yet reading through the source material, it feels like the unsung hero of gastroenterology. Like it's the linchpin of the entire operation.
It absolutely is.
Yeah.
The guide wire is a thin, highly flexible wire that is introduced into the esophagus before any dilator is used. The doctor carefully threads the tip of this wire down the throat and navigates it through the center of the stricture, advancing it safely into the stomach below.
Okay.
Once that wire is established, the dilating tool, whether it's a bougie or a balloon, is threaded over the wire. It rides the wire down like a train on a track.
I love that analogy.
Yeah. In fact, the terminology shifts when a wire is involved. A bougie passed over a guide wire is specifically referred to as a savory dilator.
A savory dilator. Okay, I want to push back on the logistics of this, though, especially regarding those terrifying complex strictures.
Sure.
If a complex stricture is twisty, angulated, and visually opaque, meaning the doctor literally cannot see the other side, how are they safely threading a wire through it? If you push a wire down a blind, twisting tunnel, aren't you just risking snapping the wall of the esophagus?
That is the exact risk the guide wire is designed to mitigate. A rigid bougie acting as a battering ram in a blind curve will absolutely plow straight through the tissue.
Right.
But a guide wire is engineered with a specialized, highly flexible, often floppy tip. As the doctor slowly advances it, the soft tip deflects off the walls, gently feeling its way along the path of least resistance.
Which is the actual anatomical opening.
Yes, no matter how narrow or winding it is, it finds the true path through the dark.
Wow. So the wire goes in first to map the curves of the tunnel, laying down a physical track. Then when the doctor pushes the heavy wedge-like bougie down, the bougie has no choice but to follow the exact path of the wire,
Safely around the blind curves.
rather than just driving straight into the wall of the organ.
Exactly. The wire eliminates the danger of the tool deviating from the anatomy. It prevents 2 catastrophic failures.
Right.
First, it stops the dilator from coiling up in the open, healthy space above a very tight stricture.
Right, like if the wedge hits a hard wall of scar tissue and the doctor keeps pushing, the tool might just bend and loop back on itself.
Exactly. And second, and vastly more critical, the guide wire prevents perforation.
Perforation, meaning the tool literally tears a hole completely through the wall of the esophagus and into the chest cavity.
Which is a profound, life-threatening medical emergency. I mean, the esophagus sits right near the heart, the lungs, and major blood vessels.
Oh, wow.
Yeah. A perforation introduces bacteria and stomach contents into the sterile chest cavity. The stakes of applying intense mechanical force inside a delicate organ just cannot be overstated.
So the guide wire ensures that the brute force of the dilator is directed exclusively against the scarred lumen. It keeps the instruments strictly confined to the safe track.
Exactly. It's the ultimate safety net.
Okay, so we have the map, simple versus complex. We have the physics, the forward wedge of the bougie, the inside-out stretch of the hydrostatic balloon, and the life-saving train track of the guide wire.
Right.
The final phase of Dr. Raju's conceptual framework is execution. It is about matching the specific tool to the terrain.
Yes, the geometric classification dictates the surgical protocol. Let's apply this to simple strictures first. These are the short, straight Chaskey's rings, or the mucosal webs we talked about.
Right, the straight shots.
And then because the path is perfectly straight, and the doctor has an unbroken visual line of sight through the narrowing, the protocol allows these to be safely dilated using a bougie on its own.
So laying down the guide wire track is optional here.
Right. The physician can use a guide wire if they feel it's appropriate, but the foundational protocol states that simple strictures can be dilated with or without one. The inherent straightness of the anatomy provides the necessary safety margin for the wedge to do its work.
But the moment the terrain changes, the rules become absolute. If the stricture's tight, twisty, opaque, or ulcerated, if it's a complex stricture, the guide wire is mandatory. There is no optionality.
None.
The doctor must use a wire-guided bougie, the savory dilator, or a wire-guided balloon.
Because the doctor is essentially flying blind in a complex stricture. Pushing force into a dark, angulated curve without a track to guide the tool is a recipe for perforation. The complexity of the scar tissue demands the safety infrastructure of the wire.
Okay, this brings up a major question about medical logic. If the guide wire is this incredible life-saving safety net that completely prevents the tool from puncturing the esophagus, why not make it mandatory for every single procedure?
It's a fair question.
Like, why skip the safety net on a simple stricture even if you can see the end of the tunnel? Isn't more safety always better?
It seems counterintuitive, I know, but in medicine, more intervention does not always equal more safety. Every time a physician introduces a new instrument or an additional step into a procedure, they are introducing a new variable.
I see.
Passing a guide wire requires time, manipulation, and physical interaction with the tissue. If a stricture is exceptionally short, completely straight, and relatively open, the doctor can clearly see the target. Pushing a wire through first and then threading a bougie over it adds an unnecessary step to an already visible, straightforward path.
You're adding complexity to a simple problem.
Exactly. It extends the duration of the procedure without providing a proportional safety benefit. Good medical practice is a highly calculated escalation of force and intervention.
Right.
You do not deploy a complex, multi-step navigational tool when you have a clear, straight shot. But the second the anatomy becomes unpredictable, you escalate to the wire.
It is a fascinating balance of risk, physics, and human anatomy. Let's trace the full arc of this journey one last time because it's wild. It always begins with a chemical crisis, right?
Right.
Severe esophagitis, usually driven by stomach acid, burns the delicate lining of the throat. The body panics and mounts a defense, laying down dense, thick layers of collagen to patch the burns.
But that collagen, the fibrosis, lacks the elasticity of healthy muscle. Over time, it builds up and constricts, creating a rigid narrowing called a stricture. The patient's natural ability to swallow is compromised by their own body's healing mechanism.
And then the gastroenterologist has to step in and map the damage. They categorize the stricture geometrically. Is it simple, like a short, straight ring or web with a clear line of sight?
Or is it complex, a tight, twisty, dark tunnel of heavy peptic scarring?
Right. And once the map is drawn, they select the tools to physically break the rigid collagen. They rely on the forward linear wedge of the bougie or the predictable radial expansion of a hydrostatic balloon.
And for those blind, terrifying, complex curves, they depend entirely on the soft, flexible tip of a guide wire.
To safely map the path first, ensuring the dilators stretch the scar tissue without tearing a catastrophic hole through the organ itself
is an incredible synthesis of understanding biology to solve what is ultimately a mechanical engineering problem.
We owe a huge debt of gratitude to the source material for today's deep dive, Dr. Gadamukala S. Raju, and his lecture, Stricture Dilation Concepts. It takes a procedure that happens behind the closed doors of an endoscopy suite and makes the physics of it entirely accessible.
It really highlights the extreme precision required to manipulate human tissue safely. It is a very delicate, high-stakes environment.
It really makes you rethink the mundane act of eating. The next time you sit down, take a bite of food and swallow it without a second thought, take a moment to appreciate the engineering inside your chest. Appreciate the smooth, unscarred, perfectly elastic muscular tube that coordinates that entire invisible journey. But before we sign off, I know you had one final thought about the underlying biology of this whole process.
Yeah, I did. We've spent this entire discussion detailing how doctors utilize brute mechanical force wedges and water balloons to tear open rigid scar tissue. But consider the biological catalyst we discussed at the very beginning. The original fibrosis formed as a protective, hyperactive healing response to inflammation and injury. The body felt damage, and it built a scar.
Right. It was just trying to help.
So when a doctor forcefully tears and stretches that tight tissue to widen the esophagus, they're creating a massive new microtrauma in that exact same spot.
Oh, wow.
Right. What is to stop the patient's body from interpreting that dilation as a fresh injury and immediately, aggressively building an even thicker wall of scar tissue right back over the newly opened tunnel the second the procedure is finished.
Oh, that is a brilliant, lingering puzzle to leave on. You can fix the plumbing with brute force, but how do you stop the pipe from immediately trying to crush itself all over again? Thank you so much for joining us on this deep dive into the hidden mechanics of the human body. Keep wondering about the systems running on autopilot inside you, and we will catch you on the next one.